Thank you. Bismillahirrahmanirrahim. Hadith of the day. Whoever brought his Muslim brother out of discomfort, Allah will bring him out of comfort of the day of resurrection. Assalamu alaikum everyone. I am Dr. Marina Akhtar, PGR Community Medicine. My topic of presentation is Cytomegalovirus. I am presenting this topic under the kind supervision of Professor Dr. Saira Afzal. Learning outlines. Case presentation, epidemiological triad, level of prevention, congenital cytomegalovirus, diagnosis of cytomegalovirus infection, treatment of cytomegalovirus infection, recent updates and MCQs. Learning outcome. At the end of this presentation, participant would be able to describe the clinical feature of cytomegalovirus, its epidemiological triad, prevention, treatment, and recent advances. Case presentation. The patient presented with acute mononucleosis and colitis caused by primary cytomegalovirus infection. This was characterized by the presence of atypical lymphocytes and hepatosplenomegaly. Elevation of transaminase levels, serology positive anti-CMV IgM and CMV antigenemia. Additionally, CMV positive cells were histologically detected in colonic biopsy specimens. The patient's symptoms and clinical parameters improved by initiation of intravenous ganciclovir. It was concluded that even if the patient with ulcerative colitis are not treated with steroids or immunosuppressants, significant attention should be paid to acute cytomegalovirus infections in contexts of severe or persistent chronic inflammation. Cytomegalovirus. Cytomegalovirus is common herpes virus infection with wide range of symptoms from no symptoms to fever, fatigue, resembling infectious mononucleosis to severe symptoms involving eyes, brains, other internal organs. Cytomegalovirus is also known as heterophile negative mononucleosis. Epstein-Barr virus is also known as heterophile positive mononucleosis. Herpes virus. There are 9 types of herpes virus. Herpes simplex 1 and 2, varicella zoster virus, which is human herpes virus 3, Epstein-Barr virus, which is human herpes virus 4, human cytomegalovirus or human herpes virus 5, human herpes virus 6A, 6B, human herpes virus 7, Kaposis, sarcoma associated herpes virus, also known as human herpes virus 8. History. Smith in 1956, Rowe and co-workers in 1956, and Weller et al. In 1957 independently isolated human cytomegalovirus strains. In 1960, Weller and co-workers proposed the term cytomegalovirus and subsequently isolated CMV from the urine of infants with generalized disease. Problem statement. In the United States, nearly 1 in 3 children are already infected with cytomegalovirus by age 5. Over half of the adults have been infected with cytomegalovirus by age 40. Once cytomegalovirus is in a person's body, it stays there for life and can reactivate. A person can also be reinfected with a different strain of virus. Most people with the cytomegalovirus infection have no symptoms and are not aware that they have been infected. So, cytomegalovirus has now become one of the most opportunistic pathogen encountered in the patient immunocompromised from congenital or acquired causes such as AIDS and transplant procedures. Epidemiological triad. Agent. Beta herpes virus type 5, the largest in herpes virus, double-stranded DNA enveloped virus nucleocapsid, 105 nanometer in diameter and 1 62 capsomers. Host: age, gender, immunity, and pregnancy. Cytomegalovirus infects people of all ages. Over half of adults have been infected with cytomegalovirus by age 40. Gender: both genders are can equally be infected. Immunity: immunocompromised patients are more infected, and pregnancy, also pregnant females are more prone to infection. Source is body secretions, that is saliva, urine, semen, blood, and breast milk. Mode of transmission: it transmitted via saliva, sexual contact, placental transfer, breastfeeding, blood transfusion, solid organ transplant, hematopoietic stem cell transplantation. Incubation period 4 to 8 weeks. Clinical features: fever, sore throat, fatigue, swollen glands. Occasionally, cytomegalovirus can cause mononucleosis or hepatitis. People with weakened immune system who get CMV can have more serious symptoms affecting the eyes, lungs, liver, esophagus, stomach, and intestine. Now, case presentation for congenital cytomegalovirus infection. A 4-month-old baby girl presented with complaint of vomiting, diarrhea, body contraction. It was reported that the girl had been vomiting whatever she had eaten 3 to 5 episodes and having watery diarrhea 2 to 3 episodes since previous weeks. Moreover, for the last 3 days, he had experienced a few contractions in her arm 3 to 4 episodes per day. The parents were found to have first degree consanguinity, and mother had history of C-section delivery. The patient had microcephaly, long eyelashes, up the nose, high arched palate, retrognathia, distinctive ears, and short neck. She had medial deviation of second finger, agenesis of middle finger, and syndactyly of fourth and fifth fingers of the right foot. Moreover, she had irregular foot lines. Bilateral choriorhinitis was determined at the ophthalmological examination. The patient had impaired neuromotor development and had no control of her head and neck. Investigation were done. Hepatitis markers, HBsAg and anti-HBc IgM and anti-HCV all were negative, anti-HAV IgM negative, and anti-HAV IgG positive. Toxoplasmosis, Epstein-Barr virus, herpes simplex virus 1 and 2, rubella, parvovirus B19, and HIV serology were all negative. Serum cytomegalovirus IgM was positive, IgG was positive. Urine cytomegalovirus DNA PCR was 3,303 million copies per milliliter. The mother's serum cytomegalovirus IgM was negative and IgG was positive. Congenital infection defined as isolation of cytomegalovirus from saliva or urine within 3 weeks of birth. The commonest congenital viral infection affects 0.3 to 1% of all live births. The second most common cause of mental handicap after Down syndrome and responsible for more cases of congenital damage than rubella. In cytomegalovirus infected neonates, only 10 to 15% of newborns are symptomatic at birth, and serious complication occurs later in life. Here shown the symptoms of congenital cytomegalovirus, sign and symptoms: permanent visual impairment, brain abnormality, microcephaly, mental retardation, permanent hearing impairment, premature birth, low birth weight, coordination disorder, liver, lung, spleen issues, and epilepsy. Cytomegalovirus infectious sources could be breast milk, immune complex and toddler through urine and saliva, sex, semen, cervical secretions, and uterine infection leads to placental infection, which could be primary or recurrent, and fetal transmission 20 to 40%. Then it leads to symptomatic 5 to 10% infants. Intrauterine growth retardation, retinitis, microcephaly, jaundice, hepatosplenomegaly. In asymptomatic in 90 to 95% patient. Then In symptomatic patient, permanent damage could take place, 50 to 80% mental retardation, deafness, and blindness. And in 20%, it leads to death. And in asymptomatic patients, late squealy deafness, learning deficiency in 7 to 25% people can take place. Complications of complications are retinitis, colitis, esophagitis, hepatitis, encephalitis, and pneumonia. Levels of prevention: primary, secondary, and tertiary. Cytomegalovirus is preventable. Pregnant women who already have young children, who work with young children, are at high risk of catching cytomegalovirus infection. Cytomegalovirus is found in home and daycare settings. Avoid contact with saliva. Kissing kids under the age of 6 on forehead instead of lips and cheeks. 75% of toddlers have cytomegalovirus in their urine or saliva. In studies, the child care setting. Wash your hands after contact with bodily fluid of kids under age of 6. Don't share utensils, drinks, or toothbrush with kids under age of 6. Primary prevention includes health promotion, specific protection, health education. Wash your hand often. Avoid contact with tears and saliva from when you kiss a child. Avoid sharing food or drink out of same glass as others. Be careful with disposable items. Clean toys and practice safe sex. Vaccine. No licensed vaccine is available. There is candidate live attenuated vaccine known as Tawny strain, but there are concerns about administering a live vaccine which could become latent and reactivate. Prevention of cytomegalovirus disease in transplant recipient is very complicated subject and varies from center to center. It may include following measures: screening and matching. Screening and matching the cytomegalovirus status of the donor and recipient. Use of cytomegalovirus negative blood for transfusion. Administration of cytomegalovirus immunoglobulins or seronegative recipients prior to transplant. Give antiviral agents such as acyclovir, gencyclovir prophylactically. Secondary prevention. Secondary and tertiary preventions are the most important in this disease. It includes early diagnosis, prompt treatment. Cytomegalovirus can be transmitted through breastfeeding, so it is necessary to start antiviral therapy for mothers, and breastfeeding should be discontinued. Diagnosis of cytomegalovirus. Quantitative cytomegalovirus DNA by PCR diagnosis and monitor response. Number 2, qualitative cytomegalovirus DNA detection by PCR is extremely sensitive but not specific, can't differentiate active or latent. Tissue culture, this is delayed diagnosis. Serum cytomegalovirus, IgM, IgG antibodies, good for screening. Histopathology, delayed diagnosis, and inadequate specimen collection. Treatment. Treat with full dose IV gencyclovir or oral valganciclovir. Monitor cytomegalovirus viral load or antigenemia once weekly while on therapy. Generally continue treatment until undetectable. May consider 1 to 3 month course of secondary prophylaxis after completion of treatment. Cytomegalovirus infection in the transplant recipient. Cytomegalovirus infection is multifaceted phenomena with variety of direct and indirect effects in organ transplant recipient. Cytomegalovirus can disseminate to various organs and can cause death. Symptoms in transplant patient: fever, arthralgia, pneumonia, GI ulcer, hepatitis, multi-organ disease. In CDC, cytomegalovirus is a common virus that infects people of all ages. Over half of the adults have been infected with cytomegalovirus by age 40. Most people infected with CMV show no sign symptom when baby born to cytomegalovirus infection. It is called congenital cytomegalovirus. About 1 out of every 200 babies is born with the congenital cytomegalovirus infection. About 1 in 5 babies with congenital cytomegalovirus infection will have long-term health problems. And out of 5 babies, congenital cytomegalovirus will have symptom or long-term health problems such as hearing loss. In most severe cases, CMV can cause pregnancy loss. Now coming to the recent updates, here is the article Congenital Cytomegalovirus Infection Update on Diagnosis and Treatment. Congenital cytomegalovirus infection is the most common congenital viral infection, is leading non-genetic cause of the sensorineural hearing loss and important cause of neurodevelopment disabilities. The risk of intrauterine transmission is highest when the primary infection occurs during pregnancy, with higher rate of vertical transmission in mother with older gestational age at infection, while the risk of adverse fetal effects significantly increase if the fetal infection occur during first half of pregnancy. Despite the prevalence and morbidity among the neonatal population, there is not yet standardized diagnostic test therapeutic approach of congenital cytomegalovirus. This narrative review aims to explore the latest development in the diagnosis and treatment of congenital cytomegalovirus infection. Literature analysis show preventive intervention other than behavior measures during pregnancy are still lacking, although many clinical trials currently ongoing formulate the vaccine for women before pregnancy. Currently, we recommend using PCR assay in the blood, urine, saliva in neonates with suspected congenital cytomegalovirus infection. At present, there are no evidence of benefit of antiviral therapy in asymptomatic infants. In case of symptomatic congenital cytomegalovirus, we actually recommend treatment with oral cyclovir for duration of 12 months. The effectiveness and tolerability of therapy option have proven effective for hearing and neurodevelopment long-term outcomes. Valganciclovir is reserved for congenitally infected neonates with symptomatic disease at birth, such as microcephaly, intracranial calcification, abnormal CF index, and chorioretinitis or sensory neural hearing loss. Treatment with antiviral drug not routinely recommended for neonates with mildly symptomatic disease at birth, neonates under 32 weeks of gestational age, or infants more than 30 days old because of insufficient evidence from studies. However, since the population represents a vast majority of neonates and infants with congenital cytomegalovirus infection, they are at risk of developing late onset sequelae, and biomarkers able to predict long-term sequelae should also be found justify starting treatment and reducing the burden of cytomegalovirus related complication. And other article is advances in the development of therapeutics for cytomegalovirus infection. Recent development in the treatment of cytomegalovirus infection have resulted in improvement in human health and perhaps will encourage the development of new therapeutic approaches. First, the development of valganciclovir for both the prevention and treatment of cytomegalovirus infection and disease in transplant recipient has been further improved with the licensure of effectiveness and less toxic later moved. Thus, the important lesson learned from the studies in both population in the need for new antiviral agents and necessity for combination therapies has been shown to beneficial in the treatment of HIV infection. Among others, the development of mononuclear antibodies, sirtuins, and cyclopropovir may provide new treatment options. Coming to MCQs, MCQ number 1. Congenital cytomegalovirus is second leading cause of neurodevelopment delay after Down syndrome. In how many weeks isolation of cytomegalovirus from saliva and urine of infective newborn? Option A, within 1 week. Option 2, within 2 weeks. Option C, within 3 weeks. Option D, within 4 weeks. And option E, within 6 weeks.
B.
Option C is right answer, within 3 weeks. Cytomegalovirus infection is the second most common cause of the mental handicap after Down syndrome and is responsible for more cases of congenital damage than rubella. Which of the following statement is true? Babies with congenital cytomegalovirus usually have no symptoms at birth. Babies with no clinical evidence of disease at birth have no risk of having hearing or neurological development. 2/3 of the babies with congenital cytomegalovirus at birth having hearing or neurodevelopmental problem. D is diagnosis of congenital cytomegalovirus is not possible up till 6 months of life due to maternal antibodies. Option E is baby with congenital cytomegalovirus cannot survive after 6 months of age.
C.
Yes, C is the right answer. In United States, nearly 1 in 3 children are already infected with cytomegalovirus by age 5. Over half of the adults have been infected with cytomegalovirus by age 40. What is the most likely treatment of congenital cytomegalovirus infection? IV gencyclovir, oral gencyclovir referred to audiologist, managed symptomatically, treatment is not needed.
B.
B.
Option A, IV gencyclovir. MCQs number 4. Cytomegalovirus infection is the common herpes virus infection with wide range of symptoms from no symptom to fever, fatigue to severe symptom involving eyes, brains, and other internal organs. To confirm the diagnosis of cytomegalovirus, one should request which laboratory test? Option A, paired serology between mother and newborn in first weeks. Option B is IgG2 CMV in newborn. Option C is blood for cytomegalovirus DNA in first 3 months of life. Option D is urine or saliva for cytomegalovirus DNA in last 3 weeks of life. Option E is tissue culture, which is delayed diagnosis.
B.
Option D
C.
is right answer, urine or saliva for cytomegalovirus DNA in first 3 weeks of life. MCQs number 5. Which of the following does not establish diagnosis of congenital cytomegalovirus infection in the neonates? It does not establish. Option A is urine culture of cytomegalovirus. Option B is IgG CMV antibodies in the blood. Option C is intranuclear inclusion bodies in the hepatocyte. Option D is CMV viral DNA in blood by PCR. Option E is tissue culture.
E.
Yes, B is the right answer. MCQs number 6 is the prevalence of congenital cytomegalovirus infection is increasing in developing countries because of lack of awareness. Which symptom of congenital cytomegalovirus is highly reported? Jaundice, hepatosplenomegaly, choriorhinitis, microcephaly, anemia.
C.
Option A,
C.
jaundice. Option A, jaundice. MCQs number 7. Which body secretion are most common in the mode of transmission of cytomegalovirus infection? Option A is saliva. Option B is semen. Option C urine. Option D blood, and option E breast milk.
Saliva. A.
Yes, A is the right answer. A male baby boy born at 39 weeks of gestation with petechial rash, low birth weight, hepatosplenomegaly, microcephaly. This is thought that baby might be infected during pregnancy. Select the condition which likely cause the clinical presentation. Option A, rubella. B is Toxoplasma gondii. Option C is group B, streptococcus. Option D is CMV. Option E is Down syndrome. Oh, sorry.
A.
Option D. 9. Organ transplantation is one of the complicated procedure. The risk of infection is highly reported in these patients. The most common viral infection after solid organ transplantation between 1 to 4 months of surgery. Option A, cytomegalovirus. B, herpes. C, rubella. D, HIV, and E is HCV. Answer is A. 10th MCQ is a 78-year-old man with end-stage renal disease, diabetes mellitus, microscopic polyangiitis, which he was taking glucocorticosteroid, presented in clinic with complaint of fever, painful glossitis, and taste abnormalities that had present from 1 month. The most likely diagnosis is A. Cytomegalovirus infection, B. Herpes simplex virus, C. Behçet disease, and D is syphilitic, or E is herpes zoster. Answer is A. This is key of MCQs, and these are
Okay.
references. And this is YouTube link of my present YouTube link of our channel. Kindly like and subscribe, and thank you.
Okay, thank you very much, Dr. Marina. Very nice presentation. There are few observations. First, whenever you are presenting, all the abbreviations should be avoided and full name should be written. Especially in MCQs, most of the abbreviations can be replaced by the full name. So CMV should be cytomegalovirus, HIV should be human immunodeficiency virus, and so on. Second important thing is that whenever we talk about the recent advances, we always give important guidelines that have been changed. So over the years, we have seen that the cytomegalovirus has so the cytomegalovirus they have been changed over the year, especially for mononucleosis and for liver problems, hepatitis, and the immune system that the cytomegalovirus causes severe weakness, leading to the symptoms including eye symptoms, lungs, liver, esophagus, stomach, intestine, and many other organs. So the guidelines for the transplant of cornea for the eyes, the transplant of the liver, and the transplant of the kidney, they have been given intravenous ganciclovir as the drug of choice, and this has been given in the guidelines. In cytomegalovirus, it is further divided into a non-severe cytomegalovirus infection and also the severe form of cytomegalovirus. So their guidelines are totally different. And it is usually 4 to 6 weeks that are required to gain full activity and full immunity against cytomegalovirus. So these are my few points that should be added in your slides. Otherwise, it is a very good presentation. Thank you. Allah Hafiz.
Thank you so much, ma'am. Allah Hafiz.